So I'd like to thank everyone for being here in person and everyone for calling in from home who's able to. It's a privilege to be here for me. So I'm going to talk about treatment options after surgery and how we determine whether or not there's a benefit to getting more treatment after surgery. So after you had surgery, you take a sigh of relief, you're recovering, and you're wondering what happens next. And when you meet with your oncologist, the question to discuss is really whether you need more surgery, whether there's a benefit to getting any further surgery, or if you're going to pursue observation or surveillance and just make sure to get treatment only if your cancer comes back. What helps, I'll talk about some of the factors that determine the answer to this question, and as well as some of the options for further treatment for those patients who need it. Really what determines the benefit of further treatment after surgery is the risk of the cancer coming back. So after surgery, the pathologists are busy at work looking at your tumor, and they look at a lot of the features of the tumor that make it high risk. And this makes up the pathologic stage. So Dr. Jones at the last lecture talked about how the T stage and the thickness of the tumor determine the surgery. So the T stage also has an impact on the risk of the cancer coming back after surgery, and that helps determine whether or not there's a benefit to further treatment after surgery. The T stage is graded from T1 to T4. The number of lymph nodes, called the N stage, is also labeled from N0 to N3, and then there's something called the M stage. It stands for metastasis, and that's determined by whether melanoma spread to other parts of your body, and that's labeled from M0 to M1. Now, these letters and numbers give us a code for determining the staging group, and it's stage 1 to stage 4. Stage 1 and 2 melanomas are usually cured with surgery, so the risk of those returning is very low, so there's usually no benefit to adjuvant or additional treatment after surgery. It's the stage 3 patients I'm really going to focus on. So this is a graph of historical data looking at the risk of dying from melanoma for patients who had stage 3 melanomas. The different lines represent different categories within stage 3 tumors. So stage 3A, with only a minimal amount of one lymph node involved, those patients are on the blue line at the top, and after 10 years, there's about 90% of them are alive. So that's a fair amount. However, if you look at the bottom line, the orange line, those are stage 3 patients, 3D patients who had many lymph nodes involved, and the risk of melanoma coming back in 10 years is pretty significant. It's up to 70%. So what can we do to help this? And that's called adjuvant therapy. And this is treatment to help decrease the risk of melanoma coming back after surgery. The word adjuvant means a treatment that accompanies the primary treatment, in this case surgery. The goal of adjuvant treatment is to kill any melanoma that's remaining in your body after surgery. So the surgery takes out the main tumor, but there could be tiny bits of the tumor that remain either around where the tumor was initially or that spread to different parts of the body. And adjuvant treatment, the goal of it is to kill any remaining tumor cells and ultimately cure. I'd like to point out that the decision to pursue adjuvant treatment is really a personalized decision. There are a lot of factors that go into the decision that I'm not going to get into, including other medical conditions that you may have or your personal goals. So this is an overview, but ultimately the decision is an individualized decision with your oncologist. So the main treatment options we use for adjuvant therapy, there are two types of drugs for the most part. It's immunotherapy, including drugs Nivolumab, Pembrolizumab, and Ipilimumab, and then there's targeted therapy, which target the BRAF and MEK mutations. And I'll talk about these in more detail. So modern immunotherapy works by harnessing the power of the immune system. There are two parts of the immune system that we all have. There's the innate immune system that's made up of white blood cells called neutrophils and macrophages. This is kind of the police system of your body. These are always on. They're patrolling your body, looking for anything suspicious, like bacteria or viruses that can cause infections. If they come across anything suspicious, they attack it. To contrast that, the adaptive immune response comes from B and T lymphocyte cells. And this is kind of like the army. So these aren't always activated. They remember things from your past. So this is the basis of being immune, either from vaccines or from past infections that you might have had. Say if you had chickenpox when you were little, your T cells, you have memory T cells that recognize the chickenpox virus, and then they roam your body. And if you're exposed to the chickenpox virus 20 or 30 years later, these T cells recognize that. They call in backup, they start multiplying, and they create what's called the T cell immune response. And that's a really powerful response that ultimately kills the infection before it can cause significant damage to your body. This T cell response is also very effective against tumors such as melanoma, which are also viewed as abnormal tissue in your body. So melanoma is sneaky, however, and it has ways of evading the immune response. In the tumor microenvironment, in the area surrounding the tumor, there's something called checkpoints, immune checkpoints, that shut down the T immune response. The immune therapy that I'm going to talk about, these are drugs that target these checkpoints that shut down the inhibition of the immune system and allow activation of the T cell response against the melanoma, therefore allowing your immune system to attack the tumor. The one type of immune checkpoint is called CTLA-4. This was the first of the modern checkpoints that we have treatments that target. The drug Ipilimumab, or brand name Yervoy, targets the CTLA-4 checkpoint, and this allows the powerful T cell response by allowing the T cells to recognize the melanoma. After surgery, Ipilimumab is given by an IV for every 3 weeks for 4 doses, and then you complete a year of treatment total with getting doses every 3 months. So in the clinical trial of about 500 patients looking at Ipilimumab compared to placebo, we were split in half. Half the patients received Ipilimumab and half of them received placebo. The y-axis shows the number of patients that are living cancer-free, and the x-axis is years. So about 7 years later, patients after surgery, these are mostly stage 3 patients who receive placebo. About 30% of them remain cancer-free, compared to about 40% with Ipilimumab. So there's about a 10% reduction in the risk of cancer coming back with Ipilimumab. There's a newer checkpoint inhibitor that's called the PD-1 checkpoint. This is similar to CTLA-4. It also it's used by melanoma in the cancer environment to shut down the T cell immune response. And there are 2 drugs, Nivolumab and Pembrolizumab, that block the PD-1 checkpoint and therefore allow a powerful T cell immune response to recognize melanoma and attack it. These drugs, Nivolumab and Pembrolizumab, are given through an IV every 2 or 3 weeks for also a year. There was a large trial that was published more recently in 2017 called the Checkmate 238 trial that looked at how effective Nivolumab is compared to Ipilimumab. This was about 700 patients were split between Nivolumab and Ipilimumab after surgery. And about 2.5 years later, about 70% of these patients treated with Nivolumab were still cancer-free, compared to about 55% with Ipilimumab. So there's also about a 10% improvement or decreased risk of the cancer coming back with Nivolumab. Now, Dr. Reddy was going to talk about the side effects from these drugs and how to treat them in a few minutes. I'd just like to point out that there are side effects to these drugs, so they're not for everybody. Most of these side effects come from your immune system attacking other parts of the body that it shouldn't be attacking, because it's not only disinhibited within the tumor microenvironment, but also in other parts of the body. So moving along, the other major category of adjuvant treatment that we use is called BRAF mutation targeting. About 50% of melanoma tumors have something called the BRAF mutation within the tumor. This isn't a mutation that's passed down through your family. It's only something that's present in the tumor itself, and it's kind of a driving force. It's the engine that makes the tumor grow. We have medicines that target the BRAF enzyme that's mutated in these tumors, and it cuts off this driving force and stops the tumor from going and kills it. The BRAF enzyme also works on a pathway that has an accompanying MEK enzyme, and we have medicines that target the accompanying MEK enzyme as well. That together with the BRAF enzyme, they work better when they're treated together. These are all oral medicines, so there's a benefit of not having to get an IV medicine. And they're also given for a year. So in a large study of about 850 patients treated with the BRAF inhibitor dabrafenib and the MEK inhibitor trametinib, given over a year after surgery, you can see after about 60 months or 5 years, about 55% of patients remained cancer-free that were treated with the BRAF and MEK targeted therapy, compared to about 40 patients treated with placebo. So there's a significant improvement in living cancer-free with these drugs as well. The BRAF targeting therapy also has side effects. They're usually caused by the BRAF inhibitors targeting other parts of your body that isn't completely understood, and Dr. Reddy will talk more about these side effects and how to treat them in a few minutes. So some other adjuvant treatment options that are less often used include radiation. Giving radiation to where the tumor used to be after surgery decreases the risk of the cancer coming back immediately in that area, but not to other places. Certain tumors have a high rate of spreading to the nerves and have a higher rate of coming back in the same area, called desmoplastic tumors. That's the main use of radiation nowadays. With more effective drugs that I mentioned with immunotherapy and BRAF-targeted therapy, radiation is being used less, but there are still patients who benefit from it. Interferon alpha is an older type of medicine that we used to use more for adjuvant treatment. It is really coming out of favor. It has more side effects and it's less effective than the newer treatments I mentioned, but it's still worth mentioning. There might be patients who still benefit from it. And then newer medicines with clinical trials, such as vaccines and looking at treatment before surgery is where the treatment headed in the future. And Dr. Trong is going to talk about that. So to summarize, patients with high-risk melanomas, which are stage 3 and 4, may benefit from further treatment after surgery. The treatment options for adjuvant treatment after surgery include immunotherapy or BRAF and MEK targeted therapies. For the most part, there are other treatment options such as radiation, interferon, and clinical trials that may benefit some patients as well. And I'd like to again emphasize that the decision to pursue adjuvant treatment and which treatment to pursue is really an individualized decision. There are a lot of factors that go into making this decision, such as your other medical conditions, your personal social situation, and your personal goals that you should discuss with your oncologist, and those will be used to come up with your treatment plan. So I'd again like to thank you for coming. It's been a pleasure being here.